Right.
Yeah. I have 4:02. Do you want to start now? Does that sound
Sounds good.
reasonable, Derek?
Yeah. Okay. Well, I guess we'll get started. So thank you everyone for coming. It's my great pleasure to introduce Dr. Joseph Flynn to offer the second seminar in the Translational Epi series. Dr. Flynn is a professor of pediatrics and the Hickman Chair in Pediatric Nephrology at the University of Washington. And he is also a practicing pediatric nephrologist. He's the editor-in-chief of the journal Pediatric Nephrology and a prolific researcher in the domain of pediatric nephrology and pediatric blood pressure and hypertension. He leads the cardiovascular committee of the CKID study, of which I'm a part. It's my privilege to call him my colleague as well. And he's also an investigator of the SHIP-AHOY study, which stands for the Study of High Blood Pressure in Pediatrics, Adult Hypertension Onset in Youth. He was also the chair of the 2017 Clinical Practice Guidelines for Blood Pressure in Children, and this was the codifying document to translate epidemiologic research to clinical practice. So we thank Dr. Flynn for joining us and sharing his work in translational epidemiology. So I'll give the floor over to him.
Well, thank you, Derek. I never considered myself a translational epidemiologist until you asked me to give this talk. Hopefully I won't embarrass myself too much. Okay, here we go. So I was asked to talk about making the pediatric normative blood pressure data more accurate, and why is that important? And so I have made some assumptions in putting this talk together, in that at least some people in the audience won't know a lot of the history and background of childhood hypertension. So I've added some of that information in as well, so that everybody's on the same page. And so the outline is here. We'll talk about sort of the history of pediatric blood pressure guidelines, how hypertension is defined and why we need normative data in the first place, the process of revision of the normative data tables, and then what impact has this had on looking at both short and long-term outcomes in pediatric hypertension and childhood cardiovascular disease. So, like with many things, there is a history of the guideline development in childhood hypertension. And this was all under the auspices of the National High Blood Pressure Education Program out of the NHLBI for quite a while, going back to 1977, which was the first codified attempt to look at childhood blood pressure guidelines. And then these were updated periodically as the knowledge base improved, and as the even for what we're talking about today, the robustness of the normative data improved over time. And you can see listed here that NHLBI basically sponsored 4 series of guidelines up through 2004. And then there was a gap. And there was a gap for many reasons, one of which was because the NHLBI decided to get out of the guidelines business. So in a parallel sort of development, the European Society of Hypertension issued 2 series of pediatric blood pressure guidelines in 2009 and 2016. And we actually started work on putting together a new pediatric guideline probably around 2012. And so we were aware of the European effort while we were working on the AAP version. And we finally published our guideline in 2017 as listed there. And so why was it time? And well, of course, it had been like 12 years, which is a long time. But really, the 2004 fourth report was really a watershed document that spurred a lot of further interest in childhood hypertension. And we got to the point where this was becoming a very common pediatric diagnosis. And much of that, as we'll talk about a little bit later, was because of the childhood obesity epidemic, which was growing over the late 1980s and early 1990s. And there is increasing knowledge that high blood pressure in childhood increases the risk for adult hypertension and cardiovascular disease, and increasing evidence that youth with hypertension have target organ effects such as accelerated vascular aging. So it's clearly time, not just because time had gone by, but also because all of this other research was building at the time over that decade and a half. And so when we did the AAP guideline, we were able to make some changes in approach compared to prior guidelines. We made the evidence review much more rigorous than had been in the past. We ended up revising some of the categorization of childhood hypertension. We were able to align with the new adult hypertension guideline, which was being developed at the same time as the pediatric guideline. And I'm going to get back to that a little bit later. And then what is really relevant for this talk is that we commissioned new normative blood pressure data tables based upon blood pressures from normal weight children. And I'm going to explain why that was important. And I think that's really the foundation for why Derek asked me to give this talk. So I guess, and here's where I'll just give some background. Why do we need normative blood pressure data tables in the first place? And if we had blood pressure data tables, why did we need new ones for the 2017 guideline? So there's two major reasons. First of all is the fundamental difference in how hypertension is defined in pediatrics compared to adult medicine. And the definition, as I'll show you, requires reference blood pressure data. And all of the pediatric blood pressure guidelines since the first report in 1977 have had some sort of normative data. So they've been an important component of each guideline. And then a really important point is that our opinion, or at least my opinion as the chair of the guidelines committee, is that the prior normative data were flawed. And I'll explain why I felt that was the case. So in adult medicine, the definition of hypertension is based on what we call hard endpoints: myocardial infarction, stroke, and death. And we know that the risk of these events increases for each increment above was considered ideal blood pressure, or 115/75. And so it's always been the case that a single cut point has been used to define hypertension in adults, because we can translate events to that level of blood pressure. And in 2017, the adult guideline, which was issued by the American College of Cardiology and American Heart Association, revised their their cut point. And I think I cut something off. I think that less than 120/80 was normal and 130/80 was hypertensive. Now, in pediatrics, we don't have this kind of outcome data. And in a way, I think it's good that our patients don't have heart attacks and strokes for the most part. So we need a different way of defining hypertension. And what has been arrived at is a statistical definition based upon the distribution of blood pressure values in healthy children. And this has been the case since the 1977 report by Blumenthal and colleagues. And so, I mean, I'm almost embarrassed to show the next slide to a bunch of statisticians and epidemiologists, but as with any other biological variable, one assumes that the distribution of blood pressure values in a population follows a normal distribution, right? And so you then think about, well, from this normal distribution, what might be bad and what level might we consider to be harmful? And so what was decided was that, well, anything above the 95th percentile would be potentially harmful. And so that those blood pressure values have been considered hypertensive since that first report in 1977. And so you have the definition of hypertension displayed here from the fourth report, that hypertension is average systolic and/or diastolic blood pressure greater than or equal to the 95th percentile for sex, age, and height on 3 or more occasions. And the corresponding definition of normal blood pressure is less than the 90th percentile for sex, age, and height. And so when you define it that way, well, you need, normative data tables to be able to refer to when you're seeing a child in the office and deciding whether their blood pressure is normal or high. And so, here's just a small section of the normative data tables from the fourth report. And you can see that, they're very complicated, but which is what you end up with from this kind of a definition. And there are, values for systolic blood pressure and diastolic blood pressure on the right, and it varies by age and by height and all of that. Now, these were derived from a database of blood pressure measurements obtained in healthy children that was sort of housed at the National High Blood Pressure Education Program at NHLBI. And what you see here is sort of, and this is from the appendix of the fourth report, it tells you what were the studies that were used. These were screening studies in which healthy children had their blood pressure measured. And then the statisticians that worked with the data for the guideline, specifically Dr. Bernard Rosner, used this to derive the blood pressure percentiles and the normative data tables. And so this database was based on blood pressure measurements obtained in about 65,000 healthy children. And what was different about the database for the fourth report was that it added new data from the NHANES 3 and NHANES 1999 to 2000 surveys, which was felt to be a good thing because now there were more children involved, they were more contemporary, and we knew that their blood pressure was being measured in a standardized way. But there is actually a problem in doing that, and the problem is here. So beginning in the late 1980s, the childhood obesity epidemic really took off. And you can see here that as the data that were being used to add to the database for the normative data, as those data were being collected, the prevalence of obesity in childhood was increasing. And there are multiple problems with that, because we know that obesity is a major driver for development of hypertension in the first place. And so it was, thought that, well, maybe the data are better, but then this paper came out, and I see that Bonnie Faulkner is there, and she was the chair of the committee for the fourth report. And when this paper came out by Paul Muntner, talking about the increased prevalence of childhood hypertension, and came to this conclusion that the blood pressure has increased, the level of blood pressure has increased and that was attributable in part to the obesity epidemic. I remember Bonnie and I had a conversation about this, and we're like, uh-oh, this is potentially a problem then with the normative data. And we actually sort of recognized that, and there was I can remember a discussion amongst the group about how this might be a problem, but I think we were already at the point where we couldn't change anything, or maybe there were other things going on. I think maybe this paper came out like right after the fourth report came out, or right around the same time. And then even studies that were being done in school districts. So this is a paper from John Soroff, who did school screening studies in Houston, in the Houston suburbs, and showed that, children whose BMI was higher had more frequent prevalence of hypertension. And these are the children that were added to the database. And so we recognized this. I think it was recognized by some people, but it's really interesting about how short people's memories can be, because then I think we talked about it and sort of worried about it, but then the rest of the world didn't seem to think much about it. But a few of us remembered. And so actually, I think the paper that Derek really was highlighting with this talk was this paper, where Dr. Faulkner and Dr. Rosner and a few other people thought it was important to actually look at the blood pressure data in a different way, because what is the impact of having these overweight children in the normative blood pressure database? Are we really saying that a higher level of blood pressure that is created from childhood obesity is okay? And so, in other words, are you accepting that a pathological process is healthy? And so because the percentile data update for the fourth report did not take into account weight or BMI, are we making that excess weight, increased blood pressure from that excess weight normal? But that these data were collected while the prevalence of childhood obesity was still increasing. So, to have that continue and to continue incorporating blood pressure data from those quote unquote healthy children is going to eventually result in higher normative blood pressure values. And, I think that we felt this was a problem. And so what Dr. Rosner and colleagues then did was say, well, let's go back to the normative, to this database, and let's pull out those children with overweight or obesity. So any child with a BMI of 85th percentile or above. And then let's look at the blood pressure data based on just healthy weight children. And so that left about 50,000 children in the database. And of no surprise, proportionately more were removed from the later and Haynes surveys, because those were the surveys in which 15% of the children had abnormal weight. And then the paper goes into many, many pages of different statistical modeling, which are, as Derek knows, I'm a good consumer of statistics, but I'm no statistician. And so perhaps that's a discussion you guys can have after this talk. But many different models were looked at as to how to fit the data best, because it's not a linear relationship between blood pressure, height, and age. And so anyway, the outcome was they decided that quantile regression gave the best fit and it was most flexible. And so just like before, blood pressure curves and tables were produced. And so these were the curves. This is the curve for 90th percentile of systolic and diastolic blood pressure for boys and girls using quantile regression. And these looked a lot better than the curves produced by other methods. And they also included, tables, sort of like the tables that were in the fourth report. And they even looked at, well, what does this mean? And so they looked at all of the blood pressures in the database and showed that when you looked at the overweight children, in other words, children whose BMI is over the 85th percentile, the percentage of them who had elevated blood pressure was much higher than those in the normal weight group. And so here is the proof in the pudding that higher blood pressure resulted in, skewing the blood pressure values upward. And and I think this was a very important paper and an important analysis, but, it got forgotten, actually, or never really became utilized, which I think is interesting. I don't know why, but so anyway, but a few of us remembered. So fast forward to the development of the clinical practice guideline. So we knew that the fourth report tables had been generated from this other database, that many of the children had overweight or obesity, and that inclusion of those children biased the normative data. So we said, hello, Dr. Rosner, we need you. And so we actually commissioned Dr. Rosner to develop new blood pressure tables for the new clinical practice guideline based upon their prior work in that 2008 paper. And basically, I forced the AAP to pay to have these things done because I said, we are not basing a new guideline on those data. And so I was fortunately able to make that happen. And so no surprise, and so new blood pressure tables came out, and they're complicated, which is a talk for another time, but here's an example. And what's not surprising is that these are lower than the values in the fourth report by 1 to 4 millimeters of mercury. Really interestingly, there had been a paper published a year or a little bit more before our paper, before the clinical practice guideline, that had combined some different databases of normative blood pressure from across the world and called them the international standard. And if you look at the CPG tables and this in this paper, they're very similar, and which is no surprise because in some of the parts of the world that were used to develop the international table, the prevalence of childhood obesity is lower than in the United States. And so anyway, what does this all mean? So if your normative blood pressure values are lower, then it follows that you're probably going to end up diagnosing more children with high blood pressure. No surprise, multiple studies have confirmed this. I just want to highlight a small number of them, which I think make the point as to why, it's important to always look at the fundamentals and think about where you're making, what you're basing your guideline on. And so, and then this is where I need to tell you again, remind you again, that the new CPG also aligned with the adult guideline for teenagers. And what that ends up doing is creating a more complicated definition where for those who have had their 13th birthday, and older, we use adult cut points here on the right-hand side. But for those children who are before their 13th birthday, we're using the percentile-based definitions, which are detailed here. And if you really are interested, you can, look at the paper. So there have been a lot of studies that have looked at the impact of the guideline. A former fellow of mine, Eliza Blanchette, and I wrote this paper about 1.5 years ago that pulled together the data studies that have been published up to then. And I'm not going to go through all of them, but there's a few I think that are really interesting to look at. So Sharma and colleagues, they went back to the NHANES data, the more recent NHANES data, and they compared the prevalence of high blood pressure between using the fourth report normative data and the CPG normative data. And they applied that to 16,000 children who had their blood pressure measured between 1999 and 2014 in the NHANES. And they also were able to look at other things like laboratory data, overweight, and lipids and things like that. And so when they looked at that, they found that overall the prevalence of high blood pressure increased from, and that combines pre-hypertension plus hypertension, from 12% to 14%. So that's an increase. And then when you do the comparison, I'll just walk you through for children, this top line. So for children who are considered to have normal blood pressure by the fourth report tables, and applying the CPG tables, so only 97% of them still had normal blood pressure. Now almost 3% of them had elevated blood pressure, and then some of them had blood pressure that would have been at the stage 1 hypertension level. And you can see this happening for the pre-hypertensive group. Many more of them were classified as stage 1 hypertension. Oops. Same for the stage 1 hypertension. Now it's children classified as stage 2. And the children who had, and about overall 6% were reclassified upward. And of those who were reclassified upward, a lot of them had overweight, obesity, they had abnormal lipids, or they had abnormal glucose metabolism. And so these are all known additional cardiovascular risk factors. So seem to be pretty good at picking out children who had elevated cardiovascular risk. And then this paper looked at, well, what about children with target organ damage? And so this was a small study that already had data. These were children with known obesity or type 2 diabetes who had gone through a comprehensive evaluation for hypertensive target organ damage with echo, pulse wave velocity, and carotid intima media thickness measurements. And so they look at how frequently was there increased LV mass, diastolic dysfunction, thickened carotid arteries, etc. And compared to the prevalences using fourth report data and CPG data. And so I'm sure you won't be surprised that they found that there was more children who've been classified as hypertensive. That's like the prior study showed. And they showed that many of those who had prehypertension were reclassified as stage 1 hypertension, and that the CPG classification was much more sensitive for detecting hypertensive target organ damage than the fourth report classification. And you can see that here, where the percentages of children with these different manifestations of hypertensive target organ damage were greater using the CPG tables than using the fourth report tables. And then one last study, well, what about prediction of adult cardiovascular disease? Because isn't that why we're interested in childhood hypertension in the first place? We want to know what kids need to change their lifestyle or be treated with the medications so they don't have heart attacks when they're 40 or 50 or 60. And so Elaine Urbina's group was able to look at data from Bogalusa, so 4,000 participants who had childhood blood pressure measurements and then adult outcome data. And so they went back in time and applied the fourth report normative data and the CPG normative data in them. And well, no surprise, more of them were classified as having elevated blood pressure using the CPG data. And they found that, if you then looked at the adult outcome, well, more had LVH in adults if you had used the new normative data to classify those people, and that they had like 10% were reclassified as hypertensive, and they had more adult cardiovascular disease matched to against matched normotensive participants. And then these are just the odds ratios for the children who were reclassified upward. And I don't have time to go into all the detail, but they did show, that there was much greater odds ratio of an adverse adult cardiovascular outcome had you identified those people using the new normative blood pressure data. Okay, so to get sort of towards the end here, finally, Tammy Brady, who I know was on in the group earlier, she and Elaine produced this really nice summary paper, just came out this month online, where they looked at sort of summarizing all of the studies that I talked about and that Eliza and I had looked at. And so I really recommend this paper to you. And I pulled out 2 quotes from their discussion, which I thought really summed it up very nicely. So, updating the normative blood pressure database to be normal by excluding children with overweight and obesity, and endorsing the use of adult static cut points, changes the estimates of hypertension and even cardiovascular disease in children. They actually identify more, and there's a global increase in hypertension prevalence. And all of the studies that have been published since the guideline came out have shown that the key action statements endorsed by the guideline allow us to, better identify the children who are at risk and need to have something done. And so I felt at the time that we were doing the right thing. I felt that we needed to do this as part of the new clinical practice guideline. And I think that, so far, the analysis has proven us correct. Our European colleagues have not been as enthusiastic about it. but that's a discussion for another day. And so in summary, because there's an absence of outcome-based definition for childhood hypertension, it really requires normative data that are accurate, because it's a statistical definition, at least up to now. The previously used fourth report tables, which are still endorsed by the European Society of Hypertension, were influenced by the increased prevalence of childhood obesity. And so by revising the normative data, we've actually sort of, we haven't really changed the prevalence, we've changed the identification of at-risk youth, right? And so that we think that these blood pressure values and the new classification may be more useful in figuring out which children are at increased cardiovascular risk. We are hopeful that they'll be more predictive of adult cardiovascular outcomes. Now, probably not over yet. Do we continue to add new data to the database from more recent NHANES surveys? What impact would that have? Do we maintain the exclusion of overweight and obese children? And then the database is based on auscultation, but what about oscillometric data? Because, you know, in adults, nobody auscultates anymore. And even the European pediatric guideline says, oh, oscillometric blood pressure measurement's okay in pediatrics. And actually, the Germans, I know Dr. Neuhauser pretty well. She and her group have published normative blood pressure data for children in Germany, and they use an oscillometric device. And then what I just learned about by getting up at 3 o'clock in the morning to attend the European Society of Hypertension meeting is that the Europeans are planning to develop new reference values from European children, which raises the question of whether you need country-specific data or can you have one global standard. I would think you could do a meta-analysis, and maybe someone in the audience in this talk would be the person to do it, of the currently available databases and say, okay, we have enough data, we can combine all these international cohorts, and can we just develop one standard for childhood blood pressure that could be applied worldwide? And I don't, you know, we'll have to see how that all pans out. But anyway, that's what I have to say. Thank you for your attention, and please be kind with your questions to this non-statistician.
Dr. Flynn, thank you so much. That was wonderful.
Fantastic, fantastic.
Yeah, I think there was so much epidemiology in this, and I saw some questions in the chat. I'll pass it over to Dr. Stephen Jurczek, who's an old friend and an alumni of the program, and it's great to see him on board. And please go ahead, Stephen.
Thank you so much for a great talk. I really enjoyed it, and Derek for letting me crash back in as an alumni. I just wanted to ask, you know, it seems to me that this insight about obesity is a really important one, and it has a lot of relevance to many normative standard-based approaches to defining at-risk or high populations. You know, it's apparent to me that there's other trends that have been going on during this time period. You know, sodium consumption arguably could be worsening. I'm thinking also about health disparities or other social determinants of health that could arguably be seen as worsening during the same time period. Is there any thought about looking at other exclusions that may also be relevant in terms of determining what's a true normal?
Well, the short answer is no. At least I haven't, or people I've talked to. But you know, it's an important question. The one advantage I think of the United States normative blood pressure data for children is that it does come from a multi-ethnic population, and as you know, the NHANES surveys oversample for Black participants and participants of Hispanic ethnicity. And so sure, I think the more we sort of peel back the layers of the onion regarding health disparities and social determinants of health, and we know that certain populations have things that affect their blood pressure. For example, we're learning about adverse childhood experiences and their influence on things like blood pressure and societal stress. And I think that all of those things are important, but gosh, those things are going to be really hard to tease out, right? At least with overweight and obesity, it's an anthropometric measurement that we have available for everyone, but you don't have that same, richness of data for some of those other things that you mentioned.
Thank you. Amelia Wallace is a PhD student in our department who has a question, and then I'll pass it to Dr. Apple.
Hi, this is a really great presentation. I just had a quick question about outcomes-based. Do you know if there's efforts towards like developing outcomes-based definitions of blood pressure in children, like using studies like Bogalusa? Because it seems like we're going to run into all these issues of like the child population in the US is just getting less healthy. So like trying to find a normal population is just becoming more difficult. So yeah, I don't know.
Yes, thank you for being my plant in the audience. So yes, we are working on that. Actually, the Schipple-Hoy study that Derek mentioned at the beginning is a cohort study that we are currently wrapping up of 400 otherwise healthy children with blood pressure ranging from the 75th to 95th percentiles. And we're looking at things like, we're trying to answer the question, at what level of blood pressure do the target organ effects of hypertension begin to emerge in youth? We will never have outcomes like heart attack and stroke, but we can look at intermediate measures like left ventricular hypertrophy and increased pulse wave velocity and things like that. And we're just putting out those papers now. And I don't know whether that will be sufficient to change the definition, but we do want to move in that direction.
This is Larry Apple. Thanks for presenting. I think I often say if I really, if I were to come back, I'd like to be a pediatrician trying to focus on blood pressure to prevent heart disease in adults. And your talk reinforced that. I think this issue about what is normal is key. And one thing you didn't present, and I don't know how much data are out there, are data in children in isolated populations. And a member of our group, Noel Mueller, did this, had a unique opportunity to measure blood pressure in the Yanomami Indians in southern Brazil, and it's flat. It doesn't go up with age. And we got standardized measurements using, from trained observers. It wasn't a huge study; it was cross-sectional. But it seems to me that might be you might not call it the best reference, but an important potential reference. And have there been efforts to sort of synthesize the data? And I don't know if there are, good data out there for these populations that are isolated, that don't have the age-related rise in blood pressure.
Yeah, I am aware of the data from the Yanomami Indians. I've seen that. I don't know anything about the children in that population and whether there are data specifically from children. And then I don't, So I don't know that I can really answer your question, I guess. One interesting study that I do know about is they measured blood pressure amongst children in Iceland and saw the same effects. But of course, that's a pretty developed country with the same levels of childhood obesity. And even if you look at places like, Mexico and India, even lesser developed countries are being affected by the same, childhood obesity problem. But I would have to go back to some of the primary literature, Larry. I don't really know much more to be able to answer your question.
I think those populations are becoming fewer and fewer, but even older data I think would be useful. Yeah.
I think one of the challenges that I've learned in working with some of this data is that age, sex, and height influence blood pressure to get these norms. And the analysis by Rosner and colleagues incorporated weight into that as well. So, and when we're dealing with the statistical definition, you need a lot of data for it. So it seems like a challenge to really identify that. I see Dr. Faulkner is in the audience here. Thank you for joining us. I'm wondering if perhaps you could comment on your experience in the development of these analyses.
Well, thank you for asking me. I think Joseph really sort of gave, the story very well, how we got to the current set of standards. And what he didn't mention much of why we took the harmonized the definitions with the adult definitions. The adult definitions came down, which they were the number of 130 systolic was very close to what we saw for the 95th percentile for boys. I mean, it was close, but when you stare at those percentiles, those curves in the tables, it's always the girls have lower blood pressure, and the 95th percentile is lower, and it's because they're shorter, right? They stop gaining height when they become about after 13. So I think, there will be another update at some point, and we have to see what happens, with the one definition of hypertension for both boys and girls. When you look at the tables, I mean, the 95th percentile is below 130 for girls, but, and so we will certainly pick up the overweight and obese girls, but we don't know for sure how that is going to be going forward. The other thing is that there is I'm seeing things coming out in a young adulthood, how the trajectory of blood pressure is different between women and men, and it tends to go up faster in women than in men at certain age periods. So I think we will certainly at some point, Joseph will have to start another update. So it's an evolving story of what we are learning about the epidemiology and what is normal and what's abnormal.
Yeah, very interesting. Thank you for sharing that. One thing that maybe Dr. Flynn could clarify, or Dr. Faulkner, that the 2004 guidelines, the data that was used for those were also used for the 2017 guidelines, but were analyzed under different assumptions and different constraints. Is that correct?
Well, pretty much. I mean, the main thing that
Right.
Bernie Rosner did was he took out the overweight
Yeah.
and obese. So it was limited to normal weight children, at least having a BMI less than the 85th percentile.
Yeah.
I'm not sure he.
And it is the same database.
Right.
Yeah. Yeah. Good. Who would like to ask the next question? Just very quickly, Dr. Flynn, are you treating more hypertension because of these guideline changes?
I think we're treating more hypertension because of COVID, because we've got, the entire population of the country on home restriction, and, the prevalence of overweight amongst children has just skyrocketed. And so we are seeing children who have higher blood pressure because they're heavier. But yeah, it's interesting, Derek, because the other thing that plays into our decision to treat for many of us is applying ambulatory blood pressure monitoring. And I think, we are seeing perhaps more white coat hypertension, and so not treating as many kids. And it becomes a little bit complicated depending upon whether you decide to treat based only on office measurements, which is what this whole talk is basically, about.
Yeah.
Compared to whether you incorporate ambulatory measurements and then what your other criteria are for treating.
Great. Okay, unless there are any other pressing questions, I think we can wrap up, and thank Dr. Flynn again for a great talk and his contributions today. Thank you so much.
It was
everyone,
wonderful.
for
Thank you so much, Dr.
for inviting me.
Thank you, Dr. Flynn.